And welcome back to chapter 29, chest injuries. So, chest injuries are very pertinent and severe trauma presentation, mainly because the chest protects structures that the body cannot function without. You have the lungs, the heart, and just those major blood vessels that move blood to and away from the body. So a patient may look stable at first and then quickly deteriorate if their breathing becomes ineffective, if blood begins collecting inside of the chest, or if just pressure starts to build up around the lungs or even the heart. So now in this chapter, we're going to focus on really recognizing those threats early on in your assessment. We're going to start with doing a review of the anatomy, your mechanics of ventilation, and then move into those major injury patterns, pathology patterns, assessment priorities, and then the treatments that can actually make the difference between a manageable chest injury and then a rapidly like fatal one. So chest trauma is fairly common in the medical field, and it's not a minor category of injury, right? So in the United States alone, it accounts for roughly 1 million emergency department visits each year. Okay, and a significant portion of trauma-related deaths involve the chest. So that makes early recognitions really important. Okay, so the reason that these injuries matter so much again is more anatomical. Okay, so the chest again contains the lungs, heart, great vessels. So any damage here can interfere with both a person's breathing and their circulation. The mechanism itself could be blunt, like impact from a steering wheel. It could be a fall, a sports injury, a penetrating trauma, like a stabbing, gunshot, or some type of, just any type of impalement, or it could be a combination of all of those. So from the beginning of your assessment, really the key question is not where is the injury. It is could this injury be affecting the patient's ability to breathe, to oxygenate, or to just circulate blood. So with chest trauma, any injury that interferes with breathing has to be treated rapidly, okay, and aggressively. So the body depends on really a continuous supply of oxygen. And when the chest can't move air properly, that's when tissue damage is going to develop. So, two major hidden problems are really important. Blood can collect inside the chest cavity after an injury to lung tissue, organs, those major vessels. The blood may actually compress the lung, reduce the space inside there for ventilation, or even place pressure on the heart itself. So, air can also enter areas where it doesn't belong. So, particularly in the pleural space around the lung. When air accumulates in that space, the lung is not going to be able to expand normally. And in the more severe cases, that rising, increasing pressure can actually compromise circulation as on top of their breathing. So really that's why chest injuries are assessed with, aggressiveness, urgency, even when the external wound can appear like minor, okay? So the visible injury may be, just a small clue to a much larger internal issue. So before we dive into those specific chest injuries, we need to separate two related kind of concepts, right? Ventilation and oxygenation. So ventilation is the physical movement of air into and out of the chest and the lung tissues, right? Whereas oxygenation is the movement of oxygen from the alveoli into the blood after air has reached the actual lungs. A patient can have trouble with one, or they can have trouble with both. A good example, think about fractured ribs or you have a flail segment, may make ventilation painful or just ineffective. Okay. A lung injury, fluid, blood, or collapse of the lung tissues may interfere with oxygenation, even if the patient is actually able to mechanically breathe. So now that specific distinction is important because a patient who is breathing fast and is not necessarily breathing effectively. Okay. The chest extends from the base of the neck down to the diaphragm. The lower boundary is clinically relevant because the diaphragm can rise pretty high inside the chest, especially when a patient is lying flat or they just exhaled. So a wound that appears to be in the lower chest can actually involve not only the lung, but also the structures below the diaphragm, like the liver, the spleen, or even the stomach. So the chest wall is, again, it's not just a protective cage. It is really part of the breathing mechanism. Okay. So between the ribs, again, you have muscles called the intercostal muscles. These are skeletal muscles supplied by spinal nerves, and during inhalation, they contract to lift and expand the rib cage. Now, that expansion helps create that space needed for air to move into the lungs. Okay. So if the ribs are fractured, the chest wall is unstable, or maybe the nerves and muscles can't function properly, that normal movement can be like deficient or like just distorted. The result may be shallow breathing, increased work of breathing, or just overall poor ventilations. Now, there is also an age-related point that you have to keep in mind. Very young children rely more heavily on the diaphragm because their intercostal muscles are not well developed. So, a child may show more abdominal or belly movement during breathing, and serious chest injuries may be less obvious externally than it would be in an adult. Now, running along the lower border of each rib is the neurovascular bundle. So it's a closely grouped nerve, artery, and vein. Okay, so its position specifically matters because a fractured rib can actually act like a sharp edge and tear those vessels. Could result in bleeding, and it can collect inside the chest, and that's what can contribute to a hemothorax. Which again we're going to talk about a little bit later. But each lung is also enclosed by a two-layer membrane that we're going to call the pleura. Okay, so the visceral pleura lies directly on the surface of the lung, while the parietal pleura lines the inner chest wall. Now, under normal conditions, these two surfaces kind of sit almost like against one another. They're really only separated by like a thin kind of fluid called pleural fluid. Now, that fluid is the whole purpose of it is really to reduce friction as the lung moves, like when it's inhaling and exhaling. But it also helps keep the lungs mechanically like coupled to the chest wall. So when the chest expands, the lungs are carried with it. So if air or blood separates those layers, that normal kind of relationship is going to kind of be disrupted, and the lung may no longer expand like it should. Now, the ribs, again, do form a protective cage, but they also create a flexible framework that really has to move with every single breath a person takes. Posteriorly, they attach to the thoracic vertebrae, and anteriorly, they attach to the costal cartilage to the sternum. Okay. Now, this arrangement really provides protection while still allowing the chest to be able to expand and contract. Now, inside the cage, the trachea divides into a right and left main stem bronchi. That carries air into the lungs. The heart and the great vessels are positioned kind of close by. That's going to include the aorta, pulmonary arteries, the vena cava, and the subclavian veins. Now, because these structures are kind of really close together, any type of severe impact can damage like several systems all at once. So, a patient may have a chest wall injury. They could also have impaired ventilation and a major internal bleed from that same traumatic event. But even when the patient's skin is still intact. Now, the central compartment here between the lungs is called the mediastinum. Okay, so it contains the heart, the great vessels, the trachea, and the esophagus. This arrangement really helps explain why pressure or bleeding within the chest can actually impact both breathing and circulation. So, a problem that begins on one side of the thorax may actually eventually place pressure on these central structures. Now, at the base of the thorax and the diaphragm, it separates the chest cavity from the abdominal cavity. Okay, so but it's much more than just like a divide, right? So the diaphragm again is one of the primary movers, primary muscles for ventilation. Its movement really changes the volume of the chest, and in turn can change the pressure within it. And those pressure changes, which you know, are what allow air to move into and then out of the lungs. Now, breathing itself really depends on coordinated changes in chest volume and pressure. So, during inhalation, the intercostal muscles are going to elevate and widen the rib cage, while the diaphragm is going to contract and kind of flatten. Now, as the thoracic cavity becomes larger, the pressure inside the chest is going to fall below atmospheric pressure. So then air then moves in down that pressure gradient into the lungs. Okay. So now during normal exhalation, when you're exhaling, getting that air out, the intercostal muscles and the diaphragm are going to relax. Okay. The chest wall and the lung tissues recoil towards their resting position. The volume of the thorax decreases and air flows out. Okay. Now, quiet exhalation is very passive. Okay, it shouldn't require any obvious muscular effort with those accessory muscles. So clinically, this is important. Okay, a healthy patient should not have to work visibly to actually ventilate. Okay, so when the neck, the shoulders, abdominal muscles are being kind of recruited, or when the chest movement becomes labored, restricted, the patient is spending additional energy simply to breathe. Okay, so that increased work of breathing should be recognized as respiratory distress and not dismissed because air is able to actually be moved out in and out. So you got to look at those clinical signs to say, hey, this person is in some type of respiratory distress and increase your index of suspicion for some type of pathology dealing with the airway, circulation, or a trauma. So pictured here is pretty much the respiratory cycle. Okay, so during inspiration, the sternum, the ribs move upwards and outwards while the diaphragm goes lower and becomes kind of more flat. Okay, now these movements are going to enlarge the chest in different directions, giving the lungs more room to expand. Now, during expiration, the diaphragm is going to return towards this like normal dome-looking shape, and the chest wall is going to recoil inward, and that's going to reduce the available space, and that's what causes air to move out of the body. Now, again, there's an important difference here between again quiet breathing and breathing under strain. Okay, the muscles of the neck again may assist inspiration when the usual respiratory muscles are not enough. The internal intercostal muscles, the abdominal muscles, can actively help with expiration when breathing is being more forced. Okay, so now visible use of these muscles again is not a normal function of ventilation. Okay, which again, a normal individual breathing is effortless. So it really indicates that the patient is compensating for that increased respiratory demand. So in a chest trauma, that compensation may initially preserve that air movement, but it's not going to be able to be sustained long term. So a patient who has been working hard to breathe may eventually become fatigued and then have a reduction in respiratory effort. And then become pretty much impaired become oxygenatally impaired. That's a word. Now, now that we kind of have established how the chest actually moves, again, this should all be kind of a review. We can kind of put some numbers around effective ventilation. Okay, so now tidal volume itself is the amount of air that's moved during one breath. Okay, now in an average adult at rest, it's approximately like 500 milliliters. Okay, now minute ventilation is the total volume moved in 1 minute. That's calculated by multiplying tidal volume and the respiratory rate. So a typical tidal volume of 500 milliliters at 12 breaths per minute gives a minute ventilation of about 6 liters. Okay. Now, a chest injury can reduce tidal volume because of pain, because of fractured ribs, unstable chest wall. That really just prevents the patient from taking that full breath. A patient could compensate by breathing faster, but a high rate does not necessarily mean adequate ventilations. So if every breath is extremely shallow, the total amount of useful air movement is going to still be insufficient. Now, assisted ventilations must also be controlled. Okay. Your adult BVM, bag mask device, ambu bag, that holds about 1,200 to 1,600 milliliters of air or oxygen. That's considerably more than just a normal breath. Now, that is the bag's capacity, not the volume that should actually automatically be delivered to the patient. Okay, you really only need to squeeze enough to produce a visible chest rise, and then ventilate at the appropriate rate, depending on the situation. Excessive volume or rate can really inflate the stomach, increase pressure inside the chest, reduce venous return to the heart, lower cardiac output, and in certain circumstances can potentially make a pneumothorax even worse. So excessive ventilation can also remove too much carbon dioxide, and that's going to disturb the patient's acid-base balance. Now, it is also important to note, which we're going to talk about later on, is that in the field, you can't measure a person's true tidal volume. So you're really looking at the patient's chest, their rise and fall, to determine whether or not they're actually getting sufficient amount of air inside of them. Um, Now, chest injuries themselves can be really divided into two kind of broader categories. You have closed and open. So, in a closed chest injury, the skin remains intact. These injuries are usually produced by a blunt force, like again, hitting a steering wheel, getting hit with a baseball or a bat, some type of blunt object. But really, it's where the skin is not penetrated. Okay. The bruising associated with a closed injury is really just an external sign of where force entered the body. But again, it does not reveal the full extent of the damage that could have been caused. That energy can easily pass through the chest wall, injure the ribs, the lungs, heart, major blood vessels without creating that external wound. Okay. Even a patient's like seatbelt during a car crash, you can sustain a closed chest injury. Although the restraint still substantially reduces the risk for more severe trauma, you can still get that significant bruising across the chest. But really, the important principle here is that closed does not mean minor, right? A patient can have that intact skin and still be bleeding internally, developing a collapsed lung, or just experiencing impaired heart function. So, your assessment has to be guided by the mechanism, the patient's breathing, and the overall physiologic response of the patient, rather than just how bad this patient's skin looks. Now, closed chest trauma can affect the chest wall again and those organs beneath, right? Fractures may destabilize that rib cage, create a sharp bone end that damages the pleura, lung tissue, maybe a nearby like blood vessel. Air can easily escape into the pleural space, or blood may start accumulating where you can't see it externally. So, a significant impact may also bruise the heart muscle, so that myocardium. So, if the heart can't fill normally or contract with enough force, cardiac output falls, and then cardiogenic shock could develop. This also a pulmonary contusion. So, this creates a kind of a other significant problem. This is where the lung tissue and the alveoli become bruised, and again, those tissues can fill up with blood or other types of fluid. Those alveoli can really no longer exchange gases effectively, so oxygen levels are going to fall, carbon dioxide is going to rise. We also have rib fractures. So rib fractures can add a like continuing source of injury because the chest wall moves with every single breath. So a fractured edge may repeatedly irritate or lacerate a lung or some type of blood vessel, and that can cause progressive internal bleeding. And again, if left untreated and unrecognized, hypovolemic shock. Now, these complications will, again, each receive more attention later on when we're going to kind of go more specifics. But just for now, recognize that one blunt impact can produce several like overlapping issues. Now, an open chest injury occurs when the chest wall itself is penetrated. Okay, so that penetrating object could be a knife, a bullet, shrapnel, or just any type of object that impales the chest. Okay. The initial damage occurs at the moment of penetration, but again, the patient's condition could continue to worsen as those damaged vessels continue to bleed, or if air gradually kind of accumulates inside of the chest cavity. Now, the size of the external wound can also be misleading. Even a small opening can have a deep, like track that crosses several structures, while the full path, like of a bullet or a sharp object, may not be obvious during that initial examination. So, when an object is embedded into the patient's chest, you want to leave it in place. Okay. Um, don't probe the wound. Don't move the object unnecessarily or attempt to remove it. Okay. The actual object itself may be partially like sealing the damaged blood vessel, acting as like a plug. So any type of removal could actually cause severe bleeding. It may also cause further tissue damage as it's pulled back through the chest wall. So really what you want to do is support and stabilize it to minimize its movement, then arrange a rapid transport for a more controlled removal in a surgical type setting. Any exceptional circumstance in which the object prevents resuscitation, you really need to do it by according to your local protocol. And again, get on the phone or radio with medical control for some guidance. But typically, you're always going to leave a impaled object that's still impaled in place, stabilize it. More so, unless it interferes directly with chest compressions for CPR or with the patient's airway. But again, follow your local protocol. Um, so blunt chest trauma again may result from a direct impact, to be compression, rapid acceleration, deceleration. The force can fracture an individual rib, the sternum, a large chest wall segment. It can also bruise the lungs or the heart, even when the bones are actually intact still. Rapid deceleration creates a specific risk to the aorta. Parts of the vessels are relatively kind of mobile, while other parts are fixed to the surrounding structures. So when the body suddenly stops, those sections may actually move at different rates, and that kind of creates a shearing force at the point of attachment. So a major tear can actually be catastrophic for that patient and cause severe internal bleeding. Now, similar forces can actually stretch or tear other structures from their normal attachment points inside the chest. This is really why the circumstances surrounding the injury is very important. A high-speed collision, forceful steering wheel impact, heavy crushing should create like a high index of suspicion, even when there's the patient initially appears stable. Any type of external bruising is going to help identify where the force was applied, but again, it can't measure the internal damage. So the mechanism just tells us what injuries are possible, the patient's respiratory and circulatory assessment findings. That tells us really how those injuries are affecting the body as a whole. So signs and symptoms. So the recognition of this really begins with findings that are close to the site of injury. Pain, tenderness of palpation, those are going to be common after an impact or any type of fracture. And the pain itself often becomes worse when the patient inhales, exhales, when they move or cough. Because breathing really aggravates the injury, the patient may pretty much deliberately restrict chest movement and just take smaller breaths. It's more subconsciously, but the body doesn't like to be in pain, so they're going to minimize those movements that cause pain. And in this case, means they're not going to get enough air and oxygen. Bruising and abrasions, those are going to help identify areas where force again was transferred to the chest. Any type of crepitus that's felt over a tender rib may indicate a fractured bone that's kind of moving up against one another. Palpations themselves should really be systematic, not overly aggressive, and then repeatedly pressing a painful area. That really doesn't add much more information, and it's just going to worsen the patient's discomfort. So really, you just need to palpate over it once. If the patient winces in pain or says "ow," that's enough. Okay, we know because we've assessed that area. We just move on and document. Now, a penetrating injury to the chest must be also taken very seriously. Begin. It doesn't matter how small the wound site looks like, because there's always a bunch of potential injuries beneath the skin. Okay. Again, you can damage the heart, the lungs, major blood vessels. The anterior chest, again, is not the only cause for concern. You want to also look posteriorly, laterally. Those should be examined as well. Shortness of breath or difficulty breathing is really the patient dyspnea is the patient's just feeling of discomfort while breathing. Okay, so it could be because of pain, the inability to like move your chest fully. Maybe there's compression going on in the lungs, and airway injury. There's a lot of different problems that could be causing shortness of breath. Now, a patient who reports feeling that. You need to assess not only the trauma, but then also any other type of underlying causes. But again, a thorough assessment's really required for the appropriate treatment of that patient. Now, other findings are really going to reveal how an injury has affected ventilation, oxygenation, circulation. Hemoptysis is the coughing or the spitting up of blood, right? So this suggests that there's damage to the lung tissue or just the conducting airways. Blood has entered the bronchial passages and is now being expelled as that patient coughs. You could also have unequal chest expansion, diminished breath sounds on an affected side, and that's caused because one lung is not inflating as it normally should. Now, air, blood, lung injury, disruption of the chest wall, that can easily produce that specific pattern. Now, these findings themselves become more significant when they occur on the same side as the impact or that trauma. Okay. Also, a rapid, weak pulse, falling blood pressures that could always indicate shock. The cause could be, a hemorrhage, pressures build up in the chest, or maybe even a direct injury to the heart, causing that swelling in the pericardial sac. Now, which we'll talk about later. Now, cyanosis and a falling SpO2 indicates, inadequate oxygenation. Cyanosis itself is like that bluish gray coloring around the lips, the nail beds. But yeah, you really want to look at those like the mucous membranes to kind of see that. Um, the conjunctiva, okay, may also provide a nice indication of cyanosis for patients with a darker skin pigmentation. So again, it might be a little bit harder to tell them that they have cyanosis, but again, just focus on the mucous membranes is kind of like your key there. Again, you don't want to rely, I harp on this all the time. Don't rely on just one simple vital sign to make your judgment, your clinical diagnosis, your treatment path, right? It should all be looked at as a piece of a puzzle. So in this case, don't rely just on an isolated pulse oximetry reading. Okay, a normal reading early in the assessment does not exclude a serious injury or pathology. So again, take the whole patient into consideration. But again, um, the trending of vital signs, the patient's work of breathing, the level of consciousness, and just that is what really paints your clinical picture on how you should decide how to treat this patient the most effectively. So, common respiratory patterns after a chest trauma is tachypnea combined with shallow breathing. Okay, so that just means that the patient is breathing very quickly, and that's because the body is trying to preserve that minute ventilation that we talked about. But again, each breath is small because the deeper breath is causing pain. Right, so they're breathing very fast, they're breathing very shallow. Okay, but again, that shallowness is because of the pain. So it's very important to understand and remember that respiratory rate alone doesn't mean there's adequate ventilations. A patient breathing 28, 30 times a minute, and they're going to still have very little air moving deep into the lungs. Okay. Pleuritic pain is also an issue. That is a sharp, kind of sticking pain that occurs when a patient's breathing. This develops usually when that smooth pleural space that surfaces, those become irritated or like damaged somehow, and they start rubbing against each other. Okay. Patient with this often is described as having a pain with worsening pain on deep breathing, coughing, and sudden movements. Hemoptysis, that again, as we talked about, that just means they're spitting up or coughing up blood. And that's coming from the respiratory tract. Um, again, is not to be confused with hematemesis, which is vomiting blood, which is more caused from internal bleeding in the gastrointestinal tract somewhere. So when you have a chest trauma, that is, and then you'll have a hemoptysis, where again, that is where you have a high index suspicion that there's an injury to the lungs or the airway, the airway tracts. Now, after a chest injury, again, a change in a patient's normal breathing pattern, that is what's significant. So again, look far beyond just the rate. You need to look at their depth, their effort, chest movement, air movement from the nose to the mouth, SpO2, and just whether the patient also can actually speak comfortably. Are they talking in one or two word dyspnea, shortness of breath? Um, Again, look at the entire respiratory assessment. Back to your assessment. So again, we're going to try to focus mainly on the chest injury aspect of a trauma, but we always got to harp home to our foundation, right? We got to go back there, and that's going to be our scene size up, making sure it's safe, making sure we have our BSI. Okay, so again, your assessment here is always going to be begin before you even make contact with the patient. So approach the scene, look for hazards, make sure it's safe for yourself, partners, patients, bystanders. Is there anybody there that can potentially tell you what happened? Depending on the situation, again, um, those hazards could include, oncoming traffic, unstable vehicles, heavy machinery, electrical issues, fire, exposed glass, undeployed airbags. The list goes on and on. It all depends on the environment in which you're in, but it's important to be aware of it. Okay. A special consideration is incidences that are involving assaults, shootings, any type of violent situation. Law enforcement needs to be dispatched and secure the scene prior to your arrival. And it's very common where you might arrive on scene first and not know it was a assault or some type of violent situation. But as soon as you see that someone got stabbed, there's gunshots, you might have to leave that scene again according to your protocol and wait for law enforcement to come and secure the scene. Again, because again, you're going into this very dynamic, unsafe environment. Now, if it's like an industrial plant, construction type situation, um, fire department, power company, some type of special rescue, again, they might need to be called. Again, it's all about what resources you need to mitigate any hazards on on the scene. Okay. Advanced life support is always going to be a thing to be thinking about when we're talking about a trauma. And again, advanced life support at this stage should be more focused on, hey, does the scene, does the mechanism, does the amount of patients, does that dictate an ALS call? Versus, oh, dispatch told us it was this, let's get paramedics rolling. And again, this is all dependent on your protocol, on what resources you have going to every scene. But again, this should be primarily based on the environment to dictate whether or not the mechanism is significant enough to warrant having ALS. Always use standard precautions, obviously. Gloves is the bare minimum, but again, depending on the situation, you might want to put more BSI PPE on to better protect yourself from the environment, from the patient. Blood itself may be visible as you're approaching, but again, clothing can easily conceal that, especially if it's like a dark fabric. So think about that situation when you're doing your general impression, looking for life threats, thinking about the extra BSI you might want to put on. Always have a high index of suspicion of multitude of injuries just in case, right? You don't want to be surprised when you get on scene thinking it's not a significant situation. Always think worst case scenario. But at the end of the day, good scene management is not separate from patient care. Okay. It really prevents additional casualties and just ensures that the personnel, the equipment needed for treatment and transport are already moving towards that incident, and we all have the same goal in mind. Now, once the scene is safe, you know what? Use the mechanism of injury to anticipate what may be happening beneath the chest wall. Again, we're focusing on the chest. Chest trauma is very common in your traffic collisions, falls, industrial incidences, assaults. So consider whether the patient was struck by an object, whether the object struck the chest, was the body compressed, was there again acceleration or deceleration? And again, that's kind of thinking about the shearing forces on the internal great vessels and whatnot. The mechanism does not diagnose an injury, but again, it helps direct how you're going to assess the patient. A direct blow can suggest, a rib, sternal, lung, cardiac injury. A fall or a high-speed collision. Now you're thinking multiple body systems impact. Penetrating trauma kind of raises questions about the path of the projectile, what structures are underneath. So it's very important to understand your topographic landmarks on the skin, understanding what structures are underneath. Determine the number of patients very early on. A scene that initially appears to involve just one person can contain others who have not yet been located, or their injuries are less visible, but or severe at that moment, but they're progressing. So again, survey the entire area. But really, an accurate patient count allows for the appropriate response of resources, triaging, and transport planning. Okay. Also consider the possibility of a spinal injury, right? So begin manual stabilization, SMR, when the mechanisms, the finding actually support it. But again, don't allow those measures to delay treatment of immediate threats to your breathing or circulation. But overall, the mechanism, again, just establishes your index of suspicion. So, what forces were applied to the body, what potential injuries could be there. and then you start into your primary assessment. Now, from a general impression standpoint, again, you're getting the age, sex, weight of the patient. How are they tracking you with their eyes? What's their body positioning? Do you see increased work of breathing? What are their skin signs from afar? Do they look obviously sick? Okay. All of that within a few seconds. Okay. Um, and it's going to tell you more so how aggressive you need to approach the situation, um, or how kind of should you kind of be more calm for for the benefit of the patient, because they're tracking you, they're in a seated position, you see good work of breathing, they don't appear sick. Now obviously they could still be sick and injured, but you might not want to go in there as aggressively, because now you're going to kind of cause more stress, and you might kind of miss something. Whereas if a patient is lying there, they appear to be unconscious, you're looking at for life threats, you see some uncontrolled bleeding, that changes the whole dynamic. Um, and again, I always look at the life threats being severe bleeds, whether that is bright red blood spurting out of the patient indicating an arterial bleed, or a copious amounts of dark red blood flowing from the patient, indicating a large venous bleed, where if left untreated, either could turn into a very serious situation leading to the deterioration of that patient. And again, when we're talking about trauma, we need to go it's not here yet, but we need to go with that XABC's sequencing. Okay. The X of the XABCs is exsanguating bleeding. Okay. That is going to be actually before you even start worrying about the airway and whether or not the patient's breathing and their circulation. Because you can obviously tell they're still alive. If they're actively bleeding, you can see it coming out of the patient. But you need to stop that before the patient just completely dies. Okay. With this, you are also looking for, restlessness of the patient, confusion, declining response. Again, that could also reflect hypoxia, shock, or even both. This is as we progress through our primary assessment. But again, this whole assessment, you're establishing how alert are they. You're managing their ABs, XABCs, XCABs, and then moving on to figure out what's the best method, route, plan to treat this patient. Again, just to recap again, so once bleeding has been controlled, that's when you're going to focus more back on your ABCs. Does the patient have an open airway? How do you tell? Do you need to do a head tilt chin lift, a jaw thrust maneuver? Do you want to maintain that airway with an OPA, MPA, depending on your protocol? Is there any obstructions in the mouth? Is there blood, vomitus, damage to the tongue, broken teeth that could potentially obstruct the airway? All of those elements are thrown into your airway assessment, right? Um, Looking into their breathing again, how I like to do as a patient attendant, you're going to assess everything at the same time, but again, you take priorities. So right now, everyone's learning it in a chronological order. First check this. Okay, perfect. Now check this. Perfect. Reality, you're checking multiple things all at once. And that way you gather all that information, and then you make a determination what should you treat and do first. Okay. Making sure their airway is open is more important than assessing whether or not the patient actually has adequate chest rise and fall. Because if they don't have an open airway, they're not going to have good chest rise and fall. But vice versa, the person could be breathing. It's all like that. Oh, I digress. So airway is the most important. Airway, in terms of airway, clear any obstructions, open the airway, maintain the airway. Okay. Then we assess for the breathing pattern, right? Do a rapid auscultation. Do you have diminished lung sounds, absent lung sounds, any adventitious sounds? Do you see accessory muscle use? What's their quick rhythm? What's their rhythm and rate? Is it fast? Is it slow? What's their tidal volume? Is it shallow? Is it regular? Is it deep? And then try to have a partner get an SpO2. If a patient's ventilation is failing, then you need to support it, right? You need to open up the airway, drop an OPA, MPA, depending on your situation, and then start bagging the patient with supplemental oxygen, depending on the situation. One every 6 seconds for an adult, one every 2 to 3 seconds for a pediatric or an infant. Again, making sure you're only giving enough of a breath with that BVM to see chest rise. Okay, so they don't need that full squeeze. Most patients just enough to see chest rise, and that is adequate ventilations. Um, Now the breathing assessment again continues. We're going to focus more on the chest itself. You want to expose the area, so remove the clothing from the chest, and you're going to look for injuries. Right, we're going to use our DCAP-BTLS mnemonic, and also in terms of patient dignity and modesty. Again, that it's you wanna do your best to try to minimize the exposure of the patient. You wanna try to minimize heat loss with the patient who might be in shock. All valid, right? But, the modesty aspect, though, shouldn't take priority over assessment and treatment, okay? So if you need to expose the chest to really, assess, see any injuries, you need to do it, and then after you're done, then you can cover the patient, okay? And then there are a lot of other providers, hopefully on scene, to kind of help with the controlling of the public. So again, don't make that a priority for you. But what you do need to make a priority is to assess the chest, and we've already assessed airway and breathing. So again, a part of that should be to expose the area of that chief complaint, which in this case is chest injury, difficulty breathing, and we're going to evaluate for injuries. Now, at the chest, we're looking for our normal traumas that we can see anywhere in the body, and we're going to use the mnemonic DCAP-BTLS. Okay, deformities, contusions, abrasions. I like throwing avulsions in there, punctures, penetrations, burns, tenderness, laceration, and swelling. Okay, and you want to compare the right side of the chest to the left side of the chest, right? Always look at everything bilaterally. So that's for the trauma, right? There's also more trauma. You're looking for sucking chest wounds. You're looking for flail chest segments with paradoxical chest movement. You're looking for accessory muscle use, subcutaneous emphysema. So there is more you are looking for. But right now, a quick little decap BTLS should be good. And then we also want to look for the expansion of the chest, right? So a normal chest should rise together and they should fall together, okay? Unequal expansion, again, so one side is moving more than the other. That could suggest, one of the lungs are not functioning correctly. It could be there's a chest wall dysfunction, an injury. Could be that there's a pneumothorax or a tension pneumothorax, hemopneumothorax, a whole lot of things. So again, having a thorough assessment is going to help narrow your index of suspicion and clinical impression of that patient. Auscultate those corresponding areas. Again, what we teach here in LA County is we do a rapid auscultation, mid-axillary line, fifth, sixth intercostal, bilaterally. Later on, we'll do a full set of six locations on the anterior chest, six on the posterior chest, looking at all the lobes. Perfect. Look again for those paradoxical movements. Again, that's where a section of the chest moves inward during inhalation and outward during exhalation. These findings are really going to suggest a chest segment caused by, again, multiple rib fractures, which we're going to talk about a little bit later on. And it creates what we call a flail segment. Okay. Any penetrating traumas, any penetrating wounds, again, must be managed as soon as they're identified. You could put a gloved hand you can to provide occlusion for like until you get your equipment ready. But really, what you want to do for a chest injury, if it's a sucking chest wound, you want to do a vented chest seal, or use an occlusive dressing taped on three sides or four sides, again, depending on the situation. If it's not, an occlusive dressing is still the preferred method to treat any type of penetrating wound to the chest, the neck, or the back, and I guess the abdomen as well. Uh, and we're going to talk about later. We're talking about later. Now, it's also important to not forget about the lateral chest and the posterior chest. Again, I know we're saying posterior chest is like our back, but it's still our ribs are in the back, so it all kind of correlates. And again, it's very possible a small wound on the back can be easily missed if the patient's like on their back for one, or if the wound on the chest is much larger. Okay, so it's more like a distracting injury from other potential injuries. Circulation. So, circulation assessment again always begins with a pulse check. Okay, so you should be again as the patient attendant. I do like doing a rapid pulse check and a breathing check at the same time. Grab that radial pulse and a carotid. at the same time. No more than 10 seconds, so 5 to 10, and you're really just seeing, hey, is the pulse there? Okay, is it fast, slow? Does it feel normal? What's the rhythm, and then what's the quality? So that's the strength. And again, you're just trying to see a little bit about it. Later on, you can have a partner kind of take a full like 60-second, 30-second times by two kind of check to get an actual rate. But right now, we just want to know, hey, is it fast? Is it there? How strong is it? A rapid pulse could easily indicate that they're early on in the compensatory response to their condition. It could just be to pain. It could be fear, hypoxia, blood loss. We don't really know, but there's clearly something going on. A weaker pulse, particularly when it's combined with altered mental status, deteriorating skin signs, that could suggest there's like a perfusion issue, and it's just they're not getting enough oxygenation. You want to assess the skin for temperature, moisture, and color. Now, again, depending on your protocol, you'll get an actual temperature in like Fahrenheit, Celsius. But for now, we want to know, hey, are they warm? Are they cool, cold? Are they hot? And you can just touch the patient's cheek, their forehead. If you're trying to do core temperature, they typically want you to touch the patient's belly. But just touching the cheek or the forehead is fine. Any cool, clammy skin, again, that is a really significant finding after a trauma, because pallor, which again is just another name for like paleness, it could be an indication that the body is shunting blood away from the non-essential organs like the integumentary system to the more vital organs. So that's why the patient looks pale. They're not getting enough of the same blood flow. They're gonna be sweaty or like clammy. That tells you, hey, there's something else going internally where the body's now compensating. Okay. Um, and just because it usually it could be just oxygenation issue, it could be a blood issue, but there's some type of circulation, perfusion, oxygenation issue itself. So just because you don't have a ton of blood everywhere on the outside of the patient doesn't mean that circulation is stable, right? The thoracic cavity itself can conceal a ton of hemorrhaging because again, it's just a big cavity where blood can just pool without having visible signs. Persistent tachycardia, worsening weakness, falling blood pressure, deteriorating consciousness. Again, all evidence that there might be internal bleed of some sort. So your circulation assessment, again, has to be combined with what we see externally, with what the patient's physiology is actually indicating to us. Again, a normal looking chest wall, again, does not exclude a major bleed beneath it. Um, Transport. So the transport decision, again, it follows directly from your primary assessment. Once you're done with your primary assessment, you're formulating a plan. Okay, what do you need to do? What treatment should I do? More importantly, hey, do I need ALS? Is this a BLS call? What hospital should I go to? Should I fly the patient out? Should I go by ground? Um, What's the closest, most appropriate facility? Do I want to bypass the closest hospital to go to a different one? And this could all essentially be, you should have enough information in your primary to make those decisions because you essentially have a baseline of everything that's going on with the patient in terms of vital signs, presentation, you've got a chief complaint, and that should be enough to tell you what you should do, what's your next course of action. Okay. A patient with, an airway problem, inadequate breathing, poor perfusion, hemorrhaging, uh, altered level of consciousness. All of those individually can make a patient a priority patient where you don't want to just kind of hang around on scene. You want to start moving towards definitive care. Okay. Um, the rest of your examination, you're more so looking for like non-life-saving type treatments, right? Splinting fractures, controlling basic obvious bleeds, and just further assessments. Now, to be fair, you could find a more life-threatening injury during your secondary, but they probably have other life-threatening situations that were found in the primary. So again, your decision should already be made, and then you find those other injuries later on as you're waiting for ALS while you're en route to the hospital, loading up into on the gurney into the ambulance. So it's more important to stabilize and get them packaged and en route to the hospital for definitive care, and then treating and continue your assessment while en route to that care. Um, Now, again, not every critical chest injuries is going to produce very dramatic findings, especially early on in your assessment. Subtle changes can actually be just as important. Increasing anxiety, confusion, patients having difficulty like completing a sentence, that cool, clammy skin, weakening pulses. Um, Even a patient who just says something is wrong, right? A patient knows their body, so they have this internal feeling of like this something isn't quite right. Um, there's something called a sense of impending doom. Okay, so that shouldn't just be dismissed as fear. It's like an actual legitimate symptom a patient feels when their body is. It's like a warning, so like something is going seriously wrong. So that shouldn't just be dismissed as like, oh man, they're just scared they like of the situation. Like it's a significant clinical finding. Now, hypotension, so low blood pressure, is often a late finding in your trauma. So, waiting to see that low blood pressure to tell you, like, oh, now this patient is unstable, that could be detrimental to the patient. So, that should just be treated as a late sign. Okay. The mechanism, respiratory effort, the chest findings, mental status, pulse quality, your trends in vital signs, that should all contribute to your decisions. Okay. When the patient suggests, like the patient patterns suggest inadequate ventilation, poor perfusion, um, or just like some type of internal injury, rapid transport is appropriate to a trauma center. Okay. And again, that means you might need to fly the patient out or bypass a closer receiving facility. Again, it does matter a lot on the patient, but also your local protocols and what resources you have in the area. So here we have a nice little a table. It's called the Dudley Dudley the deadly dozen chest injuries. Okay, now these really provide a framework for chest injuries that again vitally important. Okay, they're more critical situations. So some can produce like an immediate threat to the patient's airway, their ventilation. Airway obstruction, for example, we have bronchial disruption, open pneumothorax, tension pneumo, a tension pneumo or a a hemothorax. So many. These flail chest, these conditions specifically, prevent air from reaching the lungs. They stop a lung from expanding, or they just reduce the amount of functioning lung tissues. Other injuries are going to be a little bit less obvious, like a tear in the diaphragm. That can allow the organs to like move into the chest. An esophageal injury can contaminate the mediastinum, cause serious like random complications. A cardiac tamponade restricts the heart's ability to actually fill up. A traumatic injury to the thoracic aorta that can like do cause a catastrophic internal bleed. So all of these, we're going to kind of touch on some of them, but these are like the worst that you can have. Okay. Now, some of these, and a lot of them actually, can look very similar in the beginning stages of your assessment. So again, you should focus on the physiological problems and the basics. Okay, maintain the patient's airway, support ventilation and oxygenation, recognize signs of shock, control bleeding as needed, and then minimize the time to definitive care. Okay, you're not staying on scene to treat the patient. Excessively, you're treating them to kind of stabilize them enough to move them, get them in the ambulance, and start making your way to more definitive care. Now, once the moving on to our secondary assessment. Now, once we, or I guess history taking, depends how you look at the assessment in general. Once we've managed the life threats, okay, that's when you should try to gather a history. And again, that should not interrupt that essential care you're providing. You've established a chief complaint. Ask what the patient is feeling now, where the pain is located, um, whether it changes with breathing or movement, whether the breathing has been more difficult since the injury occurred. You can really utilize the sample history, but then also for the pain profile of the situation of the trauma, that OPQRST mnemonic. Okay, but really just you're investigating this from the very beginning at your scene size up, right? So you're looked at the mechanism of injury, All right, so you're thinking about, all right, how did these forces apply to the body? What tissues were impacted? If you think about it like a traffic accident, again, you're thinking about, hey, how fast the car was going, what damage has been done to the car. Was it a rollover situation, a T-bone situation, front end, rear end? Was there intrusion into the passenger compartment? Is there any starring on the windshields? Was there bent? Your steering wheel, was it bent? All of that kind of tells you, hey, what potential forces were applied to the body and where. Same thing with the fall. You want to kind of think more than just, oh, they fell, right? How high did they fall from? What what uh what area did they strike first? Like, was it on their head, their feet? What floor did they land on, like in terms of the ground? Was it concrete? Was it grass, dirt? Everything kind of tells you a little piece of information that's important for you and your treatment decision, but then also later on. With your penetrating traumas, again, what weapon or what object penetrated, right? How many wounds are there? Okay, is there any available direction of like where the shot came from, where the stab came from? So you can think about what path the object took inside the body. It's also important to find the symptoms and the signs that are pertinent. Okay. Now, pertinent doesn't mean they have it necessarily. Pertinent also can mean they don't have something. So that's where we call the pertinent positives and the pertinent negatives. So, patient has chest trauma. You're going to ask about or think about, hey, do they have shortness of breath? Do they have shallow breathing? Do they have abnormal breath sounds? Do they have deformity to the chest? Right? Do they have a flail chest or do they have paradoxical chest movement? So all those are pertinent questions to ask and to evaluate for. But just because they don't have it doesn't mean they're less pertinent. Okay. And this applies to any pathology, any trauma. Okay. There's always pertinent positives, pertinent negatives. And it's usually symptomology that you would potentially see for that specific injury or disease process. Again, collect your sample history. This is for every single patient. It's just a basic evaluation. That's where the signs and symptoms comes into play, asking those pertinent positive negatives. Is the patient allergic to anything? Are they currently taking any medications? Do they have any pertinent past medical history? When was their last oral intake? And what events led to the situation? And again, this is done on every single patient just to gather history on them. And I always say don't skip this part because there's always a chance where you arrived on scene, patient was conscious, talking to you, everything was good. Then all of a sudden, en route to the hospital, they go unconscious, they become very altered. Now that information can't be collected, right? So if they got to the hospital or went unconscious before you asked it, they can't get that information unless there's like family or bystanders around that know that information. So it is very pertinent. Okay, even though it might not necessarily be pertinent to the situation, especially if they have like just like a trauma. You don't know what other medical conditions they have that could have contributed to the trauma, or that trauma can have an impact on those medical conditions. It's a web. It's a big old web. Physical examination. Um, so for an isolated injury to the chest with kind of a limited mechanism, you're going to perform a quick body scan to confirm that there are no immediate injuries, like to life threat. So after your primary, or it could be kind of near the end of your primary, you want to, if the patient, you want to expose the area. Okay. We've already scanned the body for life threats. If the patient is conscious, we'll kind of do a focused assessment. If they're unconscious, we're going to do a full detailed assessment, but we want to do a trauma naked situation, cut all the clothes off, and scan the area for those life threats. Because as I talked about in the beginning, clothing, dark clothing, layered clothing could hide potential life threatening situations. So it's very important to see the patient's skin, evaluate for those injuries, especially if you have any type of significant injury. Okay. Now, for that isolated injury, again, the assessment um, can be really concentrated on the patient's complaint. Okay, so their chief complaint, and this is after you've scanned for life threats. Um, so if they're saying like, oh, my leg really hurts. All right, which leg? Oh, your left leg. Okay, perfect. So you're going to expose that area, and then you're going to do an assessment of that area. Okay. Um, If we're talking about chest wounds, oh, my chest really hurts. You're going to inspect the chest for wounds. Again, using your DCAP-BTLS, going through your assessment. Like, all right, again, any sucking chest wounds, any full chest segments, any subcutaneous emphysema, accessory muscle use, and again, your DCAP-BTLS. Then you're going to palpate for tenderness, instability, and crepitus, making sure you touch every single bone, or at least grouping, the clavicles, the sternum, the ribs. And again, you're assessing for that pain. Again, that's going to be the tenderness aspect. Instability, do the bones move in a way that they normally shouldn't? Or the crepitus, where you have a bone end broken and they start rubbing up on each other, kind of creating a grinding sensation. Okay. Um, and like I said, don't repeatedly palpate an injury that is, an area that is injured. Just do it one time, note it, document it, treat it as necessary, and then move on. You don't need to keep on like, oh, that's crazy, and you just keep on palpating it. It's just causing more pain to the patient. Make sure you're examining the anterior, the lateral, and the posterior aspect of the chest. Again, auscultate the epices, the mid lung, and the basis. Uh, Again, do a rapid auscultation to begin with, but then do a full set front and back. Consider the structures beneath the area as always. Again, there could always be injuries that are hidden. So look on the skin, think about the bruising and what or the penetrating trauma, and then what potential organs are underneath. Now, a significant mechanism that requires a slight different approach, right? So, blunt trauma, gunshot wound, major fall, high energy kind of collision, that again, that could affect multiple body systems. Okay. So you shouldn't just be focused on, oh, just the one like bad looking trauma, so to speak. You need to still focus on the entire body because there could be multiple different types of injuries that are significant. It's what we really call a distracting injury. A little more so like you arrive on scene and you see a person's leg is like pointing the wrong direction. You're like, oh my gosh. And they're like in a lot of pain. But that pain could be the pain, the screaming, the angulation of the actual extremity that could kind of deter you from doing a full assessment. You're just so focused on that really gruesome looking one, and you're missing a more important, pertinent life threat type situation. More times than not, we're talking about, oh, this really bad injury is taking away from managing their ABCs. Okay, but it could all be the same. So that's what I'm saying. But as I talked about, look for your DCAP-BTLS. But if we have a significant, you do want to do a head to toe assessment, doing your DCAP-BTLS, starting at the head, neck, go to your chest, abdomen, pelvis, legs, arms, and then the back when you're gonna the back as needed. Typically before you kind of put them on a back, it all depends on the situation, but if and then assess the back, okay? Now, asymmetry of the chest or the shoulder girdle, that can indicate multiple rib fractures, a crush injury, clavicular damage, some type of disruption with the chest wall. Areas of bruising and abrasion can identify where energy entered the body. Again, while punctures, lacerations, that could be more of a penetrating trauma. Burns. So burns that encircle the chest are also kind of very important because tightening tissues can actually restrict chest expansion, interfere with ventilation, the pain of the burn, and then again palpate all the areas. And we'll cover again our trauma assessment in another video, so you can kind of see the technique. But again, there are many different ways to do the same thing. As long as you're systematic and thorough, you're going to be okay. Now, after your immediate threats have been managed, and again the patient has been examined, you do want to complete that baseline set of vitals. Now, if you have enough resources, this should all be being completed as you're doing your assessment. You're asking the questions, doing your head-to-toe assessment or your focus assessment. That should be being done by other providers on scene. But if not, make sure it gets done. So again, have an actual pulse rate, respiratory rate, do a full assessment. Listen to those breath sounds, assess for effort, rate, rhythm, tidal volume, SpO2, get a patient's blood pressure, assess their skin signs, their pulses. I already said pulses. Their pupil findings. If If they're unconscious or altered, you might also go through your AEIU tips to establish, hey, why is this patient altered? Was there something that contributed to the trauma, as in they, I don't know, went unconscious because of a medical situation or other situation and crashed a car? You don't know, but always like maintain a high index of suspicion of everything, especially with what your environment tells you. Um, Patients, again, with a significant chest trauma, again, should be reassessed every 5 minutes. But really, more than that, again, your text is always going to say, oh, 5 for unstable, 15 for stable. But depending on the situation, you're going to want to continuously monitor. Okay, you're going to be in the back of the ambulance. Don't get distracted by just doing your paperwork, your filling out your patient care reports. Really continuously monitor, check on that patient just to make sure they don't deteriorate even further. Okay, because that means you might need to change your assessment protocol or your assessment plan. Um, any type of rising pulses, respiratory rate, again, that could always represent a compensatory mechanism for hypoxia, pain, a circulation issue, or just for more and the need for more for our oxygenation. A falling blood pressure, weakening pulses, narrowing pulse pressures, um, worsening skin signs, altered level of consciousness, that can again all suggest that compensatory mechanisms are starting to fail. Your respiratory trends, again, are very important as well. You know, increase in effort, maybe progressively getting shallower, falling SpO2s, worsening asymmetry of the chest. Again, all tells you that something that their breathing is deteriorating. Blood loss itself can reduce tissue oxygenation. Um, Even when your pulse oximetry hasn't shown that dramatic change. So again, your oxygen saturation has to be interpreted alongside the circulation and the patient's mental status. Later on, we're going to talk more about the serious chest injuries, and again, talk about why the respiratory rates are going to and pulse are going to begin to slow. Perfect. Now, when we're looking at the reassessment, it's really a deliberate search, if you will, for like a change in the patient's condition. Okay, a patient with chest trauma, again, they can deteriorate over a few minutes. Okay, so the fact that the airway was open or breathing was adequate during your primary assessment, it does not mean those findings are going to remain the same and be stable. Okay, so you really want to repeat the primary assessment in a systematic order. Recheck the airway, assess the patient's rate, their depth, the effort, the overall effectiveness of their breathing. Compare the patient's chest movement, breath sounds. And again, you're trying to compare it to the previous findings, right? That way you can see if there was a deliberate change or if things are staying the same, or maybe things are trending in a positive manner. Reassess the patient's pulse, their skin signs, the mental status, perfusion, and then it's always kind of overlooked, but you want to reevaluate any type of interventions you've done. More so when we're talking about your bleeding control measures, your chest seals. Make sure those are still doing what they're supposed to be doing. You also want to kind of return to look at that chief complaint. Ask, has the pain or their patient's shortness of breath, has it improved? Has it stayed the same? Has it gotten worse? If a patient is describing, an increase of pressure, is more difficult to speak, dizziness, or they just have a feeling that it's getting worse, again, that is a sign to you that, hey, something more complicated is going on, and you need to reevaluate your treatment and interventions. So the purpose here is not to just record your observations or just to take another set of vitals. It's to determine the direction in which that patient is moving. The improvement here should be supported by the findings, right? Deterioration should just simply trigger that immediate correction of the reversible problems, maybe escalate the care, and then again, progress more towards rapid transportation. Now, every intervention again has to be evaluated. Okay, I just talked about that to determine again if you're having the production of the desired effect. Okay, After oxygen has been applied, reassess the patient's O2 saturations, reassess their level of consciousness, again, their effort on their respiratory system, their skin signs. After assisted ventilations, confirm that each breath is still producing visible chest rise and that it's delivering the breath. And delivering the breath hasn't become more difficult to indicate, hey, maybe there's something else putting more pressure on the lungs to make it harder for you to comply with the BVM. Because again, that could cause worsening O2 saturations, and or there could just be something different going on that you didn't see during your initial primary assessment. Any type of penetrating wound again has should be sealed. Breathing should not just be assumed that it's going to get better. You need to reassess it, right? Reassess your chest seals, reassess your bandaging, and then make changes as necessary. A patient's position also could impact their breathing. A conscious patient whose shortness of breath becomes worse when they're lying flat, they might be able to tolerate more if they're kind of lying at a 30-degree angle or above, right? More so, put them in the position of comfort and whatever they kind of feel most comfortable in. But again, if you need to if you need to think about spinal immobilization, SMR, then you might have to kind of think about moving the entire board up if they're on a backboard. It all depends on the situation. But again, um, take that into account as well during your reassessment. Now, again, your ongoing care is directed at maintaining ventilation, oxygenation, supporting circulation, and then more so preventing delay. Okay. So when you have a significant internal bleed, for example, or respiratory compromise, you're going to provide high flow oxygen, right? If the patient can't maintain adequate ventilations, you assist with the BVM. And again, only deliver as much until you see chest rise. You want to control any significant external bleeds. If you have any type of penetrating trauma still, with the penetration still there, you want to make sure it's stabilized. You want to kind of treat any wound on the chest with an occlusive dressing, maybe a chest seal if it is indicated. And then also treat for shock. This one's missed quite often, but treat for shock by maintaining body temperature. So put a blanket on them, increase the temperature in the ambulance. Try to minimize any type of unnecessary movements, and again, rapid transport to the most appropriate facility. Pneumothorax. So we're gonna go into the more specific chest complications. So let's talk about a pneumothorax and see how that progresses, but then also some other very common traumas for the chest. Now, a pneumothorax itself is just an accumulation of air inside the pleural space. Okay, and again, that is the potential space between the lung and that inner chest wall. So the air can enter there through a defect in the chest wall, maybe escape air that's escaping through a tear in the surface of the lung. But once air is enough in there, it starts to separate the pleural surfaces. So the lung is no longer held tightly against that expanding chest wall. Um, so its natural, elastic recoil just causes it to collapse to some degree. Now, blood that continues to flow through that poorly ventilated or collapsed lung tissue cannot be oxygenated effectively. So that's where that hypoxia is going to develop. The degree and the speed of collapse really depends on the size of the injury and more so the rate of that leak. A patient could deteriorate very quickly, but a smaller leak, like if the larger it is, but a smaller leak can progress kind of over several hours. Make sure you assess breath sounds because again, they can become diminished as that lung collapses, and then a little bit further on in the development could actually disappear entirely. So these findings should really always be compared bilaterally, um, um, more so you can assess like what the healthy lung sounds like versus what the unhealthy or injured lung is. But, a sucking chest wound, for example, or just like a rushing sound at the chest wall could indicate that air is moving through the wound. But again, the absence of that sound does not exclude a penetrating injury or pneumothorax. Same thing with having bubbling on that actual wound site. Now, in this diagram, if we follow the path of air, You can actually see the leak begins at that damaged surface of the lung, okay, and then it releases air outside the lung tissue into that pleural space. So this distinction is very pertinent because the unwanted air is not filling the alveoli, right? It's collecting around the lung itself. The parietal pleura here is going to remain against the inner chest wall, while the visceral pleural moves with the recoiling lung. Now, as the layers actually begin to separate, the normal surface tension that really couples the lungs to the chest wall, that's what's lost. Okay. The ribs and the diaphragm are going to continue to move, but the affected lung is no longer pulled open efficiently by those movements. This really explains why visible respiratory effort doesn't always equal effective ventilation. The patient may be working hard, chest wall may be moving, but very little air can actually be reaching the alveoli on that specific injured side. Now, the amount of lung collapse can also vary greatly. A relatively small pneumo may produce like these like subtle findings, whereas a larger one can actually have that significant reduced oxygen exchange. But the essential mechanism here is going to be the same, though. Air in the pleural space just interrupts the mechanical relationship between the chest wall and the lung itself. Now, when the opening extends through the chest wall, okay, the injury is actually called a pneumothorax. Okay, so it's often referred to as a sucking chest wound. Okay, so air can move directly between the atmosphere and the pleural space, interfering with that normal native pressure type ventilation. Now, after ensuring that the airway is open, you're providing oxygen, rapidly covering the wound. Okay, that is what you should be doing. Clear the space, and then you should apply a vented chest seal. Okay. Now, a commercially available one is kind of like the preferred method, and the whole design of it is to prevent air from being drawn into the wound while still allowing trapped air to escape. Okay. Now, the one-way component is kind of what we call a flutter valve. Um, you want to apply the device according to, again, the manufacturer's instruction and your protocol. Okay. The skin may need to be cleared of any blood, any moisture. So a lot of those ones are going to come with a little like piece of gauze, a little 4x4, so you can kind of clean the area. Then you're going to open up the chest seal, again, depending on the type, and then you would apply it over the actual sucking chest wound. But it is also important to remember to inspect the back and the sides of the chest for any additional wounds, because again, every penetrating opening again has to be identified and managed, and there could always be an exit wound. Okay. Now, if you don't have one of these commercially vented seals, you could use, again, if your protocol says, an occlusive dressing, which again is more so a gauze with a water-based type lubricant, like kind of a Vaseline on it. Um, and you can apply that to the area and then tape it on three sides. Okay. Now, whichever device you use, reassessment here is going to be one of the most critical elements because increasing respiratory distress, if you're getting worsening unilateral breath sounds, failing oxygen saturation, signs of shock, after you've already kind of sealed the wound, that could indicate that air is becoming trapped inside the cavity even more so. Okay. So a non-vented dressing may be needed to briefly like lift, maybe to be applied. And again, it all depends on the protocol. Because if it's getting worse, not getting better, you're just going to more so tape it on all four sides. So here again, here's like another diagram of like that air going in and out, right? So it represents the more so the air passing through the chest wall defect or the injury during the respiratory cycle. So during inhalation, that negative pressure develops within the thorax, but instead of all the air entering through the trachea and reaching the alveoli, some may be drawn through the wound and directly into that pleural space. During exhalation, air can rush back out through that same opening. So that movement can actually produce the characteristics of a sucking, bubbling, or just a rushing sound that's associated with an open pneumothorax. Blood around the wound can also bubble with each breath, but although air is like visibly moving, this is not like a useful type ventilation. Air entering the pleural space really does not participate in that gas exchange process. But instead, it just more separates the lung from the chest wall, and that just encourages a progression of collapse. Now, again, this sounds dramatic, but it's not always present, right? So, clothing, blood tissue, patient position, uh, a relatively like small wound that could easily just what's called hide it, right? So it can camouflage it. So it's not always just that huge gaping wound that's very dramatic, right? So little things could actually hide it. Now, recognition again is really dependent on a complete examination, a complete assessment, right? Rather than just like, oh, is there a sucking chest wound? Perfect. Now you want to kind of again do a full assessment. Do you have diminished lung sounds? Do you have some type of open wound? How's the patient responding? Are their oxygen levels failing? And then again, getting your trends on your vital signs. Now, a simple pneumothorax is one of that has really not produced major changes in the cardiac physiology. But again, the word simple just describes it more physiologic effect. It doesn't necessarily mean that the injury is like not important or not critical. Okay. Now, these injuries, commonly follow like a blunt trauma where a fractured rib damages the pleura or the lung itself. Now, early findings for this one, you're gonna have sharp pleuritic pain. So again, pain when they're breathing, shortness of breath, tachypnea, accessory muscle use, gradual kind of declining SpO2. Now, breath sounds again may not become obviously diminished until like a larger portion of the lung has collapsed. So you might have normal or kind of close to being normal sounds early on. But again, that shouldn't just completely dismiss the potential of a pneumothorax. Air may also escape in the soft tissues of the chest wall. And if that does happen, when you palpate, you're going to have something called subcutaneous emphysema. Okay, so now that is like a fine crackling sensation beneath the skin. So when you're palpating, you're going to feel like little Rice Krispie snap, crackle, pop. Um, now, this is different from like a deeper grinding sensation, which is that crepitus, right? But again, both findings are sometimes described using that word crepitus. The patient also might experience lethargy, cyanosis, and then just diminished breath sounds a little bit later on. But in reality, a simple pneumothorax can develop, okay, it can develop associated bleeding, progress into a tension pneumothorax. And that's why it's very important to have a repetitive assessment. And that's more important than just kind of trying to find the correct, clinical diagnosis in the field. Now, management of a suspected simple pneumo is more or less supportive. Provide high flow O2 if the patient's hypoxic or in respiratory compromise. Continue to monitor their oxygen saturations, their breathing effort, chest movement, breath sounds, and continuously during transport. You want to treat any associated injuries without really losing sight of the overall respiratory problem, right? Rib fractures, external wounds, shock, they all require your specific attention, but none should really delay access to that higher level of care, okay? You want to request advanced life support early on so the patient can actually get more definitive treatment, but as long as it's not delaying your arrival to the hospital. Now, positive pressure ventilations, that requires, again, more specific care. Introducing pressure into an injured lung can actually increase the air leak and contribute to the development of a tension pneumo. But assisted ventilations, again, you can't withhold that when the patient isn't breathing adequately. So, so again, you need to treat that. So hypoventilation, respiratory failure, those are going to be immediate threats. So when ventilation is required, you want to just use controlled breathing, deliver again only enough to see visible chest rise and fall, and then again continuously reassess. If there's a sudden increase in resistance, worsening, chest movement, SpO2 is falling, or there's just overall circulatory deterioration, that should really raise concerns that pressure is just building in that pleural space. Now tension pneumo. So a tension pneumothorax develops when just air continues to enter the pleural space and it just can't escape. The injured tissue may act as kind of like a one-way flap, or like kind of an external wound may become like sealed while air continues to leak from the lung. Um, So with each breath, there's more air accumulation, and the intrathoracic pressure is just going to steadily rise. Now, the affected lung itself eventually will collapse completely. Okay, so the rising pressures then is going to push the mediastinum towards the opposite side of the chest. This can also cause a compression of the vena cava, and which is going to interfere with the blood returning to the heart. So with less venous return, the heart has to actually has less blood to pump. So that means that cardiac output's going to fall, and then shock is going to start to develop. Now, the opposite lung may also become compressed. So ventilations again are going to become progressively worse at the same time that the circulation is failing. So that's why really attention pneumothorax is a respiratory emergency, but it's also a form of obstructive shock. Okay. Now, blunt trauma involving a fractured rib, a lacerated lung, this is going to be a really common cause, but a tension pneumo can also develop after a penetrating trauma. If there's issues with your chest seal or just issues with your positive pressure ventilations. But really, the important feature here is not the original mechanism. It's just the continuing accumulation of that pressurized air and the resulting compromise of both your patient's breathing and their circulation. So overall recognitions, you have your common signs and symptoms. It's going to include, chest pain, respiratory distress, tachycardia, low and progressively failing SpO2, and then absent or diminished breath sounds on the affected side. Subcutaneous emphysema can also be present. So, as pressure begins to interfere with circulation, the patient is going to become weak. Um, their pulse is going to decline, maybe hypotension, altered mental status, skin signs issues, cool, clammy, signs of shock. Some other big ones are like jugular vein distension, cyanosis, tracheal deviation, but those aren't reliably present, especially tracheal deviation is going to be more of a later sign. And again, it just means your trachea is moving away from where that lung is collapsing because it's putting so much pressure on the mediastinum that everything is pushing to the opposite side. Now, treatment itself is in the hospital setting. Again, shouldn't or pre-hospital setting really shouldn't delay transport because again they need that definitive care at the hospital setting to relieve that pressure because they need what's called a needle decompression. And now some ALS entities can do that in the field, but again, it all depends on your local protocol. Where is ALS compared to the hospital? There's a lot of variables here. But your basic care just includes high concentration of oxygen, assisted ventilations, um, again, ALS activation, and then immediate transport. Now, if deterioration follows the application of that occlusive dressing to an open wound, assess whether the dressing needs to be vented and or just completely sealed. Now, throughout care, you really want to avoid excessive ventilations and get notify the advanced the hospital of all your findings, and then update them if things are becoming more difficult to treat or ventilate that patient. Now, the illustration represents what we call an advanced tension pneumothorax, right? So, on the injured side, you have what's like this pressurized air that fills the pleural space and it compresses the lungs towards the center, okay? So, the intercostal spaces and the tissues may appear expanded because the actual pressure is pushing outward against the chest wall. Now, it's also important to note that the pressure is also pushing towards inward towards the mediastinum, right? So the heart, the major blood vessels, those are going to be displaced and then compressed. So the vena cava here is particularly important because the compression will really limit the blood's return to the heart. So even if the heart muscle is uninjured, it can't maintain adequate output when it's not actually receiving enough blood. Now, on the opposite lung, it's also losing space as the mediastinum is actually shifting towards it, right? So this means the patient's no longer really dealing only with a collapsed lung; they're dealing with a collapse of both lungs. The remaining lung is really becoming compressed, while the circulation is also again, simultaneously being obstructed. Now, this image is more on the dramatic side of the stage, right? So it's clinically significant, right, that the pressure is going to develop because more obvious external bulging or the tracheal shift is seen. So that's why tracheal deviation is one of more of the late signs of attention pneumo. Now, again, it's important to recognize the combination of worsening unilateral kind of ventilation and the deteriorating perfusion fairly early on in your assessment, rather than just waiting for all those advanced like features and symptoms to actually show up. Now, the air is also not the only substance that can actually occupy that pleural space. In a what we call a hemothorax, the blood can actually collect between the lung and the chest wall after some type of injury to the vessels that are like surrounding the rib cage, maybe the lung itself, or one of the great vessels. So in the diagrams that you can see here, there's like two different problems that are occurring, right? So you have the accumulation of blood that's occupying the space and it's compressing the lung, right? But it's also reducing ventilations and impacting the oxygen exchange on that impacted side. Now, the other issue is that blood has like left the the circulatory system rather, right? So the patient is developing hypovolemia and shock, even though very little blood is actually coming out externally. Right. So now this combination makes a hemothorax very dangerous. Okay. So the patient can deteriorate not only from impaired breathing, but also from internal blood loss or a combination of the two. Uh, During your assessment, breath sounds are really important because, again, you're going to have diminished or absent lung sounds on that compressed side, while also the pulse and the skin signs are going to be worsening with the impact on the perfusion. Now, the location of the blood inside the thorax will also explain why an external like assessment can be kind of misleading, right? There can be a very minor looking wound or even like an entirely closed chest wall that's concealing that internal hemorrhage. Now, the mechanism and the patient's physiologic response has to carry more weight in these situations than just, again, what you see in terms of blood loss from the outside. Now, you should really suspect a hemothorax when a patient's chest trauma starts developing signs of shock, again, without any type of external bleeds. It's really important when the patient's breath sounds are also diminished on one side. Now, the injury may follow a blunt trauma, penetrating trauma, and really several structures may be bleeding all at once. So, unlike external hemorrhaging, bleeding into that pleural space cannot usually be controlled in that pre-hospital setting. So, treatment is going to be more on the supportive side, making sure the patient's oxygenated, ventilated, prevent heat loss, recognizing signs of shock, and really just minimizing the time to that definitive care. The receiving facility really has to be capable of inserting a chest tube and just managing major internal bleeds, including like surgery. So going to the appropriate facility is going to be more in line with your definitive care interventions. Now, air and blood also could collect together, right? So this again is going to be called a hemopneumothorax. So now in that situation, the lung is compressed by both, again, the blood and the air, and the patient may show a mixture of respiratory compromise and, again, some type of hypovolemic shock. Now, the precise differentiation between a pneumothorax, hemothorax, a hemopneumothorax, that's might not be possible in the field, right? So it's really less important to recognize that, and it's more important to ensure proper ventilation, proper perfusion, and ensure and just to assess for those signs. So in reality, you should just support the physiological problems that you're finding, communicate that there's could be a suspected internal chest injury, and then again transport rapidly to the most appropriate facility. Now, A different type situation that could arise, that's also dealing with pressure, can actually develop around the heart, okay? And that's called a cardiac tamponade. Now, this occurs when there's actual blood that's accumulating inside the pericardial sac, okay? Now, the pericardial sac itself is like a fibrous protective layer that surrounds the heart. The heart must relax, as and fill before it can actually contract effectively. So that's kind of that's the whole point, right? So your heart contracts, it kind of gets a little bit smaller, and that sac is just surrounding it. So again, it gets smaller, it gets bigger, it gets smaller, it gets bigger. Um, Now, as fluid builds up within that kind of pericardial space, the chambers are going to be compressed and they're not going to be able to expand normally during the filling phase. So there's going to be less blood that's going to enter the ventricles, and less blood is going to be available to be pumped in for normal circulation. Now, that result in reduction is going to kind of result in a lowering of your stroke volume and lowering of your cardiac output, which will then lead to shock. Now, this is another form of obstructive shock. So blood may still be present in that vascular system, but the heart is physically prevented from filling and pumping it effectively. Okay. Now, in a trauma situation, a tamponade is especially associated with injuries that allow blood to enter the pericardial sac. That could be a penetrating wound, a laceration involving the heart, or some type of nearby vessel in the area. The external wound, again, could be very small, while the internal effect could be fatal. Okay, so recognition is very important, and it should be based on the pattern of chest trauma and the deterioration of perfusion in that patient. That should be your more clinical relevant signs versus just does the wound look bad. So here we have a good image, kind of comparing the normal heart and then a heart that is actually surrounded by fluid in the pericardial sac. Okay. Again, every time the heart contracts, it gets a little bit smaller, but that allows more blood, more fluid to get into that pericardial sac area. And that just puts more pressure on the heart, and the heart is less able to expand to its normal position. And that's kind of the situation that we find ourselves in. Um, Now, the speed in which that accumulation occurs is actually very important, right? So the pericardium really has a little opportunity to stretch during like this acute traumatic bleed. So even a relatively small amount of rapidly accumulating blood can actually cause severe compression of the chambers. The fluid that actually accumulates more slowly can actually occur over weeks or months, and it can be tolerated a little bit longer. And those, so it doesn't turn into an immediate life threat, or not necessarily a life threat, but a recognizable threat. But in reality, the visual distinction here is that the problem is not primarily that the heart is weak or enlarged heart muscle. It's an external compression that prevents normal filling. Okay, so your definitive treatment here again is going to be all about relieving that pressure, and unfortunately, you cannot do that in a pre-hospital setting. You're going to have to do that in the clinical setting. Now, a cardiac tamponade, again, it commonly presents as shock after a chest trauma. Now, the classic pattern, and this is very important to remember, is associated with what we call Beck's triad, and that is the common symptomology that the patient is going to present. So you're going to have hypotension, okay, jugular vein distension, and then muffled heart tones. Now, as the patient's cardiac output falls, the pulse is going to become rapid and weak, and the difference between the systolic and diastolic pressures are actually going to start to narrow. With jugular vein distension, this is going to occur because the blood can't move efficiently through the compressed right side of the heart, and it begins to back up into the venous system. Your heart sounds are going to become muffled because the fluid that surrounds the heart, again, is going to make it a little bit more difficult to actually hear the heart the contractions, like that wubbed up sound. Now, don't expect every component of Beck's triad to actually just present itself early on. These early findings can usually be subtle and really be associated with blood loss, and it can alter the appearance of those neck veins. So, Really, a declining level of consciousness may be more obvious as that patient's cerebral perfusion starts to worsen. But again, your pre-hospital treatment is just going to be supportive, right? Maintain the patient's airway, provide oxygen as needed, assist ventilations as needed, and then just treat for shock and transport. Okay. Again, transporting to the correct facility is going to be the primary thing you can actually do for that patient. So, in reality, as an EMT, a pre-hospital care provider, the key is just going to be able to recognize the deteriorating perfusion after a chest trauma, and that the symptoms could be caused by mechanical compression of the heart. And again, even when there's minimal trauma that's actually associated with it. Now, rib fractures, they're particularly common in the elderly individuals. Um, and it's kind of associated with elderly patients, even with like a very minimal, modest type of trauma to them. But really, the seriousness of the injury kind of depends more so on um, what ribs were broken, which ribs, how many ribs, are they in the same set? Because we're going to talk about something called the flow chest in a second. But um, when we're talking about the upper ribs, okay, so that those are protected more by your clavicles, your scapulae, the surrounding musculature. So fracturing one of these ribs usually requires like a lot of force, and that should kind of raise concern for an injury to the lungs, maybe the heart, the aorta. But whereas a fractured rib can also create a sharp like internal edge. So continued chest movement may also cause the edge to lacerate the pleura, the lung tissues, or the neurovascular bundle beneath the ribs. So any complications can really include, from a rib fracture. It could be a pneumothorax, a tension hemothorax, some type of combination of, again, of any of those. Now, the older age, multiple fractures, fractures on both sides of the chest, those are all going to increase the respiratory complications that you might find. The fracture itself, again, could be painful, but the major concern is whether the pain or the underlying organ injury is compromising ventilation and oxygenation, because that's kind of always going to revert back to that, right? Managing the patient's airway, their breathing, and their circulation. Now, a patient with an isolated rib fracture, they usually describe it as kind of like an isolated tenderness and pain that just becomes worse when they inhale, when they move, or when they cough. The patient may actually be holding the injured area in an attempt to like self-stabilize, to limit any motion, and just kind of reduce discomfort. Now that is more of a psychological type situation where your body instinctively will react to try to limit the pain. Okay. But now there is also an issue with that psychological behavior because deeper breathing can cause more pain. So respirations for these patients usually become a little bit more rapid and a little bit more shallow. Okay. So now as tidal volume starts to fall and the patient is not ventilating effectively, despite having a good respiratory rate or an increased respiratory rate, that could be more detrimental to the patient than the actual just injury, right? So, and so we'll have to deal with that. Now, when you're doing your assessment, it's important to assess the chest kind of gently for the tenderness and stability of the crepitus. Once you've identified the exact location or like have a good idea, you don't need to continue to palpate it. Compare breath sounds on both sides. Make sure you're looking for adequate chest expansion on both sides. Because again, you always have to be on the lookout for that pneumothorax, that hemothorax that can develop, after your initial examination. So having a very thorough primary assessment is going to pay dividends later on when you're doing your reassessment. You want to provide supplemental oxygen when, again, that patient is in respiratory distress or hypoxemia. Now, again, the goal, again, depending on your textbook, maintain that SpO2, that oxygen saturation level between 94, 98%, 94, 99%. And again, unless your patient's clinical circumstances are different or your protocol is a little different. Um, In terms of positioning the patient, just allow them to be in a position that kind of supports their own breathing, minimize unnecessary movement, and then again, arrange a transport to the appropriate facility. It's important not to become focused on that pain that's developing respiratory compromise, because or don't just focus on the patient's pain. You really want to focus more on the patient's oxygenation, their ventilatory compromise. That's kind of what you're looking for. Philologist. So now this is kind of the more critical issue when you have a potential rib fracture, and that's when you have two or more rib fractures in two or more places, right? And it basically creates a portion of the chest wall that becomes mechanically detached from the rest of the cage. Okay. Now, this unstable section is what we call a flail segment. But the overall injury is called a flail chest. Now, it's a similar kind of pattern um, that could involve the sternum and separation of the costochondral joints and junctions. But what's really happening is that during inhalation, negative pressure would normally pull the entire chest wall outward as the lung expands, right? So a detached segment is no longer supported in the same way. So it really has to be drawn, it's going to be drawn inward while the surrounding chest expands outwards. Now, during exhalation, it may move outward while the remainder of the chest actually recoils inward. Okay, so this is like the opposite movement, and we call that paradoxical chest motion. Okay. Now, abnormal movement here reduces the mechanical efficiency of breathing, really, particularly when that segment is fairly large. Pain from the fracture actually is going to also have issues with the patient's tidal volume. So again, ventilations are going to become increasingly inadequate. That paradoxical motion can be subtle and may not be visible like right when you arrive on scene, but again, it could develop as it could just develop as your assessment goes on. Um, Now, muscle tension, really, patient position, shallow breathing, that could actually temporarily limit the movement, but its absence does not, exclude the chance of a flail segment or that it's there. So again, the big issue we're going to talk about is that it's all about friction, right? So as that motion or that rib segment is moving opposite, you're creating a lot of friction on that lung, and that's when that friction can rub away and then cause a pneumothorax. Now, once you recognize it, let's talk about like what the actual treatments are. Okay. So your goal again should be to support ventilations, support oxygenation, support circulation. Okay. During this situation, the patient again could be compensating with rapid breathing, but those breaths are going to usually be too shallow to provide adequate tidal volume down to the alveoli. Now, pain in this situation again is going to be more of a contributor to that shallow breathing, but also every movement of the fractured ribs can be very uncomfortable, and then so what that patient is going to do is they're consciously not going to take those deep breaths. So doing pain management, again, when it's appropriate in your protocol, if you have ALS support, that can actually assist with the patient breathing normally and therefore getting more oxygenation. But again, that pain management really should, or waiting for pain management, shouldn't delay your transport, right? Because again, they need more definitive care in the clinical setting. Now, that force again that is being created by that flail segment um, has a potential to injure the lung. The rib cage can again penetrate the pleural space, the lung itself, and then causing a pneumothorax, which again, just it's going to have a domino effect, causing shock, and it's a whole thing. Now, when the patient's breathing has finally become inadequate enough where their oxygenation has failed or is on the decline, that's when you might need to assist with positive pressure ventilations using a bag valve mask, right? Now, again, the reasons why you use a BVM is the patient has either shallow respirations or sorry ventilations, synonymous. They have poor chest rise and fall. They're breathing too fast, too slow. Those would be reasons to start bagging a patient, right? Now, usually you're going to have more associated symptoms. So if you have very low tidal volume, you're going to see changes in the patient's mental status. You're going to see increase in cyanosis. You're going to see failing SpO2 numbers. So again, all of that kind of plays a role into bagging a patient. Okay. Now, your purpose is really to restore effective ventilations, not to really force the flail segment into a normal position. Okay. So really, you just want to continue to monitor the patient's breath sounds. Is there any resistance when you're using a BVM? Um, and again, you want to make sure you're not overinflating. Only give enough of breath to see visible chest rise. Um, Now, this is one of the pathologies or traumas that have actually changed in terms of treatment. You still might be under the same type of what's called protocol at the moment, but we used to just again use a big bulky dressing to kind of stabilize and immobilize that chest segment. But again, that's no longer recommended. So, because restricting that chest wall can actually further limit expansion and make ventilation less effective. So that's kind of why they're going further away from that. Because again, it is impairing the patient's ability to breathe more, and at least effectively. Uh, and essentially, what they're saying is that there's less of a the 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 reason we did that to have that bulky dressing was to try to prevent that friction from occurring, so you didn't have that rub on the lungs where you could have the popping of the lung or some type of injury. But now we're saying, hey, you know what? That is going to limit the patient's breathing, and we got to focus more on the patient's breathing and their oxygenation versus the smaller chance of an actual pneumothorax from occurring. So that's kind of where we're going at the moment. Now, in a couple of years, that might change back, but right now we're going more towards just worry about the oxygenation, the ventilation of the patient. So now moving on to other chest injuries that are kind of fairly common, you have what's called a pulmonary contusion. Now, this is a bruising of the actual lung tissue. The traumatic force really damages the delicate tissues around the alveoli, the capillaries, around the blood, and it just allows the blood and fluid to actually collect within that area, that injured area. Now, those fluid-filled alveoli really can't exchange gases normally. So the blood that's actually passing through part of the lung may leave without actually receiving any oxygen. Now, this differs from a pneumothorax, in which the pneumothorax collects air in the pleural space and prevents that normal expansion, right? So in a pulmonary contusion, the principal problem really is inside the lung tissue where the gas exchange surfaces have been damaged. Now, the condition may not be fully, recognized in the field, but fluid accumulation can develop over, several hours. So a patient who initially has, acceptable breath sounds, oxygen saturations, they're going to deteriorate later on. Now, there could be increasing respiratory effort, progressively shallow breathing, falling SpO2s, restlessness, altered level of consciousness. That really should be treated as significant changes in a patient's condition when we're talking about any type of chest trauma. The pulmonary contusion should be kind of suspected whenever there's a severe blunt force to the actual chest. Now, that's also very true when there's also a flail chest. Okay, so again, you're going to have multiple traumas from one incident. So now, what do? You provide supplemental oxygen, assist with ventilations, and then as indicated. But that's pretty much all you can do. Just more supportive than anything. But again, further assessment, prompt transport, and then just support ABCs. Um, a sternal fracture. Now, a fracture of the sternum will require a lot of force, right? The sternum lies directly in front of the heart, the lungs, again, your aorta. So any type of fracture, again, has to be viewed as a potentially serious mechanism for that patient. So look for associated respiratory compromise, abnormal pulse characteristics, falling blood pressures, really any type of finding that could indicate there's an injury deeper than just on the sternum. For clavicle fractures, that's also very common. The clavicle overlies the first rib and just helps protect a large, like neurovascular bundle that is supplying the upper extremities. So um, damage to this area near the kind of medial end of the clavicle may also have associated injury with the upper ribs. Again, so that could have an impact on circulation, could have an impact on nerves, could have an impact on the actual lung. Now, any type of pain, swelling, any obvious deformity, that's obviously going to draw your attention. To that area, and it could actually draw it further away from the chest. So you got to kind of make sure you stay focused, and continuously assess vital signs. Check those breath sounds on bilaterally. Look at the chest rise and fall for each, and then just watch for any type of development of a pneumothorax. Now, the patient's circulation, movement sensation in that affected arm should also be checked. Again, so that's going to be have the patient wiggle their fingers. What finger am I touching? Check those pulses, because again, any type of impact to that area could impact that circulation or that nerve bundle. But again, this is very common for any type of fracture to the chest or anywhere really on the body. The fracture itself, yeah, is not great, right? But we have to think beyond the fracture, right? We have to think about the underlying structures that could have been damaged, because that can have a more systemic effect on the patient's well-being. Traumatic asphyxia. Now, this results from a really sudden, severe compression of the chest, right? So, this may occur when a person's like pinned beneath the car, trapped between a heavy object, or compressed against a structure, okay? Now, the rapid rise in this pressure inside the thorax is going to force blood backwards into the veins of the neck and the head. So, now, that really produces a distinctive pattern here. So we have distended neck veins, you're going to have cyanosis, and you're going to have these little small vessel hemorrhaging around the eyes, which we call petechia. Now, blood may also actually become visible across the white surface of the eye. So again, these are just kind of telltale signs of a traumatic asphyxia. Now, it don't be so even though it's very dramatic on the outside, again, you have to look deeper, right? it the outside appearance just reflects that sudden surge of pressure through the venous system. Okay. So the combination of a crushing mechanisms and these findings should really raise your concern about that severe internal chest trauma. Um, the external pattern here is also a warning that the visible injuries may not be the most important ones, right? So the same compression can injure the lungs, the heart, the chest wall. So your assessment needs to remain focused on ventilation, oxygenation, circulation, all the level of consciousness, and then again, any evidence of associated crush injury, rather than just on the facial appearance by itself. Now, again, those facial and eye findings that are associated with our traumatic asphyxia, again, that's just evidence of that severe event that occurred, right? But as we talked about, that same compression could have impact on the heart and the lungs. Okay, you could have a pulmonary contusion. You can have a development of a flail chest, a pneumothorax. So again, looking at the patient holistically, don't get distracted just by the outside of the patient. Uh, and as we talked about, the only management you can do is going to be supportive. Their ABCs, and then transport to the most appropriate receiving facility. Now, a blunt myocardial injury. So this occurs when the force is actually transmitted through the chest, and it bruises the heart muscle. Okay, so now this can impact both the heart's electrical stability and the ability for it to actually contract effectively. The most frequent rhythm finding is sinus tachycardia, but again, the pulse may also become irregular. Uh, Now, the only way you're going to really tell about that is tachycardia being or a fast pulse or a fast heart rate. An irregular would mean more when you're checking the rhythm. Is it consistent? The intervals between each beat kind of the same, or is it kind of sporadic? Now, in the more severe cases, more dangerous rhythms can occur, like ventricular tachycardia, ventricular fibrillation, but way less common, but it is potential. Okay. Uh, any damage. So in the severe cases, there could be damage to the myocardium. And that could impact how forceful the heart's actually contracting, which could have a significant impact on the patient's blood pressure. So then you're going to start seeing signs of poor perfusion. Okay, the patient themselves could actually report central chest pain, discomfort that kind of resembles a heart attack. But again, you have to look in the context of the situation. Yeah, the patient's exhibiting chest pain, but is it of cardiac origin or is it of traumatic origin? So that's where asking the patient, hey, what were the events leading up to the situation? What was the mechanism? It should drive you to treat it's more of a trauma versus a nature of illness. Um, Yeah, so it's important to always maintain that high index of suspicion for a blunt myocardial injury after a blunt trauma to the chest. But really, when there's bruising, tenderness, deformity, crepitus over the sternal area, again, your outside evidence might kind of be limited. But again, there could be more issues underneath. Okay. Once again, pre-hospital care is going to be supportive, ABCs, reassessment, and really you're just looking for signs of shock. You're looking for declining vital signs. That's all you can really do. But again, any type of trauma to the chest could branch out to any of these different traumatic injuries. So you have to have a high index of suspicion, gather that information, and then create some type of clinical diagnosis. Commotio cordis. Now, this has to be distinguished between a myocardial contusion. They have similar mechanisms, but they're very different pathologies, right? So instead of like developing from bruising of the heart muscle, commotio cordis is an actual immediate electrical emergency. Okay, so this occurs when there's a sudden blow directly over the heart. Right, it's delivered during a very brief, vulnerable part of the cardiac cycle. Okay, and that can actually trigger ventricular fibrillation and cardiac arrest. Now, it is most associated with sporting incidences involving like baseballs, softballs. One of the more popular or well-known cases is in football with Damar Hamlin. Um, but again, the same condition should be considered whenever someone becomes immediately unconscious and unresponsive after a direct blow to the chest. Now, treatment is going to be the same for any other cardiac arrest. Begin high quality CPR, apply an AED, and then again, just follow your resuscitation protocols. It's very important to not delay CPR or defibrillation to complete that, really drawn out head to toe examination. The rhythm itself is going to be frequently, ventricular fibrillation. So survival itself depends really on that early recognition and then early defibrillation within the first few minutes of the patient going down. Now lacerations of the great vessels. So your great vessel is going to include, your aorta, the vena cava, your pulmonary arteries and pulmonary veins, and then just any major arterial branches within the chest. So, lacerations or rupture of any of these vessels can actually cause massive internal hemorrhage, sometimes so rapidly that the injury becomes fatal before any external signs actually develop. The blood itself may remain like concealed within the thorax, but be on the alert for any type of unexplained tachycardia, weakened pulses, falling blood pressure, pale, cool, clammy skin, just altered level, any signs of shock, really. Um, the diminished breath sounds can also be present if the blood is collecting in that pleural space, and again, that's what we call that hemothorax. But there's no real practical way to control this hemorrhage in the pre-hospital setting. Again, support the airway, ventilations, oxygenation, prevent heat loss by, and treat for shock. And then again, transport to the most appropriate receiving facility. Also, early notification is very important because surgical intervention, blood product support, that's all going to be very important when you have a severe internal bleed. Okay. So that brings us to the end of this chapter. I hope you enjoyed.